Good morning and evening, everyone. We'll just get started with the webinar. Thank you for joining this webinar on defining institutional arrangements when linking financing to quality in healthcare. My name is Altea Chicho. I am economist associate, health finance specialist. Health Finance and Governance Project, and I've been leading our work on linking health financing to quality over the past 3 years, and I will be moderating this webinar. Before we get started, let me just go over some housekeeping items to ensure that you get the best experience possible. So we are using WebEx, as you know, as our webinar platform. You can join either via telephone or web. Just be sure to click on the large telephone icon once you join to make your audio selection. The WebEx platform has 2 features which you may choose to use today, the Q&A and the chat features. The buttons for these are in the top right-hand corner of the WebEx window, and clicking on these will bring up small panels on the right side of your screen. Be sure to use the Q&A feature to ask questions that you may have. We'll take time for questions towards the end, but we encourage you to submit questions throughout the session as they arise. When you're submitting a question, be sure to send it to all the panelists, and note if there is a specific individual that you would like the question. You can also use the chat feature, interact with other participants, or if you're experiencing technical issues, you will see a send to box where you can select who to send the message to. If you have technical difficulties, you can send your message to host or to my colleague Alina Sims, and she will work to address your issues. And finally, just note that this webinar is being recorded and will be available soon after the Health Finance and Governance Project website. I would like to introduce at this time the other speakers that will be part of this panel. We will be joined by Dr. Shams Saeed from WHO, Adam Kuhn from the HFG project, and Irina Guban from Moldova. Shams is currently coordinating the WHO unit that focuses on quality systems and resilience within the Department of Service Delivery and Safety at WHO's headquarters in Geneva. Adams is a governance specialist with the Health Finance and Governance Project. He's been working on our research related to this topic. And Irina is a health specialist with the World Bank in Moldova and a member of the Joint Learning Network for Universal Health Coverage. So at this time, I would like to quickly go over our agenda for today. So we will begin the webinar with an overview of the work that the HFG project has been conducting on defining institutional arrangements for linking financing to quality, part of which is qualitative research that we've conducted in Southeast Asia, and a practical guide for defining institutional arrangements. Then we will go into depth on the findings of the research study. Afterwards, we will share highlights from WHO's work on national quality policy and strategy development and its links with health financing reform. Also share experiences and lessons learned in linking quality from Moldova. And we're very pleased to have the country expert joining us today to share her experiences. And And finally, we will go through question and answers, reflect on next steps that countries can take to strengthen links between health financing and quality going forward. So, as I mentioned, HFG has been conducting work on this topic over the past 3 years. The origin of this work was that we realized that as countries work to achieve universal health coverage, maintaining and improving quality of care remained a priority, and poor quality not only prevents countries from achieving desired health outcomes, but in addition also leads to unnecessary costs. And we have been working closely with countries and understand that linking financing to quality is a powerful lever for care quality, and there has been an expression of interest from countries that we have been interacting with to understand how to go forward with putting these links in place. Strong governance is required in order to establish these links and to coordinate the roles of all the actors involved, including that of the through initial research that we did on institutional arrangements for quality and through our interactions with countries, we realized that there is a knowledge gap on governance of complex arrangements related to quality. So this is the background of the work that we've been doing so far. There are two main pieces of work that we've done that relate specifically to this topic of linking financing to quality. The first work, practical guide that we've developed, which is intended to support policymakers to define institutional roles and responsibilities of payers and how they relate to actors in carrying out strategies for improving the quality. And this guide is intended to serve as a diagnostic and planning tool to identify strategies where payers can leverage their power to enhance quality, to articulate possible institutional arrangements among payers and other quality actors, and to present a process for how to go about establishing or improving those arrangements in a particular country. So I won't go into a lot of detail on the guide, but just to give you an idea of the structure, the first part of the guide presents strategies that we identified through which payers can influence quality. So this was based on a literature review on the role of payers in governing quality in healthcare, consultation with experts and stakeholders. We came up with this conceptual framework, which includes 6 strategies or entry points through which payers can be involved in governing quality. And this framework illustrates the 6 strategies, but also maps out mechanisms and processes that can be used to execute the strategies, and then identify roles and responsibilities that would be needed to need to be in order to implement the mechanisms or processes. So for each strategy in the guide, we present promising practices and country experiences that users may take into consideration. And then the second part of the guide focuses on the process for how to establish institutional arrangements linking health financing to quality given country. So we propose a 6-step process and provide details on how to go about that. Again, this guide was developed starting with literature review to identify available resources on governing quality in healthcare, linking financing to quality, and defining institutional arrangements. We also conducted key informant interviews with stakeholders in 4 countries, followed by a workshop that we held with over 10 country participants and other experts to validate the framework that I just went over and to share experiences and challenges and lessons learned. We also conducted qualitative field research in 3 countries in Asia, followed by a validation workshop that we held regionally. And finally, we went through expert review from WHO, the IHI, APT Associates, and R4D and the JLN. And the guide was also recently piloted in Ghana, and the results of that pilot were incorporated in the final version, which will be available shortly on the HFG website. The other part of our work in this area is the research that I mentioned that was conducted in Southeast Asia, looking at the arrangements that link the quality of healthcare to health financing in Indonesia, Thailand, and the Philippines. So the research aimed to draw lessons on the ways in which these 3 countries are attempting to optimize the roles and responsibilities of various institutional actors, and to share the regional lessons learned with countries. My colleague Adam Kuhn will be going into more detail in a minute about the research findings. But before we do that, we'd like to hear from you a quick poll on which of these 3 countries that are listed here on the slide, Indonesia, Thailand, or the Philippines, you think does not have an independent third-party hospital accreditation body. You can select your answer on the right-hand side of the. You'll see a poll pop up. I think it's already there. So you can select the answer and click submit. We'll give you a few seconds to do that and then move on. So I can't see what the results of the vote were, but the answer is the Philippines. Both Thailand and Indonesia have independent hospital accreditation bodies, as it seems like the majority of you answered correctly. What we've learned through the research is that the Philippines currently have an independent accreditation body, but they are looking for moving in that direction. And they recently introduced a law that aims to do just that, to establish a third-party accreditation body that is independent from field health, which is where the accreditation function is hosted this time. So now we'll move on to the presentation of our research findings. So I will at this time hand it over to my colleague Adam Kuhn to present our research and what we found in the free country.
Thank you, Althea. And I'm happy to present the findings that have emerged from this research over the course of the last year. Next slide. So this study, drew on primarily on. So the research questions are we wanted to know, as Althea mentioned earlier, what some of the institutional arrangements are and the roles and responsibilities that govern quality of care over time, how they can be linked to different modes of health financing, and then what can our regional neighbors learn from this. That's the gist of the 3 slides that are just the 3 points that are displayed there. Next slide. So as Althea mentioned before, this builds on a lineage of work that HFG has been conducting with partners from the ASSIST project, WHO, and others over the last several years. Which started with our desk review, and this particular strain came out of questions that were identified around the governance of quality. And this is really important. This is something that emerged from a recent Lancet Global Health Commission on quality that was published a few weeks ago, where they identified even 4 kind of foundational universal action points that all governments should consider when reframing quality of global health systems. And governing for quality was one of those, setting up national level policies, defining roles and relationships, and institutional arrangements that govern them. So we conducted interviews in Thailand, Philippines, and Indonesia with with experts. There were about 20 to 35 participants, depending on country. Some countries, like Indonesia, we did interviews in at the subnational level as well. And then these were transcribed and coded in vivo. And then we held a regional validation workshop in the Philippines, in which we gathered several of the study participants as well as regional experts to discuss some of the preliminary findings. So I believe next slide. There might be a little delay in the system. So some of the, we don't have a lot of time, so I do want to cover the findings for each country, and then some of the lessons that came out of the study that cut across all of the countries. And the first was that it was somewhat surprising because of the Philippines Health Insurance Corporation is a parastatal body in the Philippines that's responsible for overseeing all matters related to health financing. They're the large health insurer, and the state-sponsored health insurer in the Philippines. And though they are responsible, as Althea mentioned in our polling section, for conducting accreditation and implementing the bench book of standards, many of the respondents saw the Department of Health in the Philippines as having a strong mandate for quality. However, it was felt that there was no clear strategy or anything really. There were different elements and pieces that had been developed over time. There was nothing bringing it all together. And as Althea suggested, there is a pending law which would help fix this, which I'll describe in a second. The other thing in the Philippines is that there is accreditation, but and that the standards are based on internationally accepted standards. And in a good way, there's a gold standard in international accreditation for health services, JCI, is being pursued by some large hospitals, and this is really for medical tourism to be a regional kind of, in a competitive regional market. However, the bad is that, by law, PhilHealth is not supposed to be conducting accreditation, and yet they're forced to do so because of complications with procurement. Many were quick to stress that somebody has to do it, even though they recognize that PhilHealth is a suboptimal entity. And then the last thing was that in the Philippines, all elements of quality, from accreditation to licensing, there's a strong role of providers in the process, in the policy process. They're not just participants, but they're also strong policy advocates and have a strong voice that they exercise. Now, in Thailand, one of the distinguishing features we found in our research there was that the National Health Security Office, which oversees the largest health insurance scheme, the Universal Coverage Scheme, has a dual governing board structure, and one of them is specifically designated to oversee and ensure quality. This monitors establishes clinical guidelines. It monitors. It's supposed to monitor key performance indicators, but it also enshrines civil society voice at all parts in the process. This is through representation on the board. And this was a unique feature, is that traditionally marginalized groups or underrepresented segments were well represented in the policy structure for governing for quality in Thailand. And then another issue is there's a flexibility. So with the key performance indicators that are used by the National Health Security Office, they actually pilot test them and adapt them to a regional context. So they're very contextually specific, which is the flexibility was seen as a positive thing. And then finally, in Thailand, many were quick to stress that the healthcare accreditation process is actually voluntary. And more importantly, perhaps, some felt that this was not a clinical audit, but this was more in terms of a comply and enforce the sanctions. But more, this was accreditation in terms of a process of getting you from one stage to the next. And this was nice, this process-oriented accreditation for working at across a variety of different types of healthcare providers. And then in Indonesia, the system is kind of dominated by this institutional flux, which is in the wake of the rollout of JK and the large universal health coverage scheme and reform efforts in the country. This led to a lot of understandable confusion in lines of communication, as well as lack of clarity and occasions across all administrative levels of actually policy intentions and designs. There is performance-based capitation in Indonesia. However, many people questioned how much it strengthens quality of the health system, because it's typically designed to reimburse for services that are curative in nature, and perhaps this overshadows some of the primary care and prevention efforts that should be incentivized through systemic improvements and incentives. And then also there's these quality and cost control boards and teams that are developed at several administrative levels involving lots of segments of the health workforce, a representation from different provider networks. However, a lot of people, when we push them about how the performance of these quality and cost control teams, they couldn't really, there was a lot of confusion about who was actually on them, and apparently maintaining kind of a regular schedule of meeting and oversight was difficult. So when we look at kind of some of the themes that cut across countries, some of these are themes we see in other areas. So, for example, the health management information systems are weak. There's a lack of, people struggle at a policy level to integrate civil society voice. There's a lack of political will, no one-size-fits-all model. These are kind of standard for all health system strengthening enterprises. But there's some other cross-cutting themes that are more more specific for our study and related to governing and quality. And that's that, a lot of actors we focused on non-financial incentives, and they were seen to matter. So this builds kind of a culture of quality within the system. In Thailand, for example, there's a Thai Quality Award, which is offered by the Ministry of Industrial Affairs, and it cuts across several sectors, of which the healthcare providers and hospitals and stuff can compete. In addition to that, Philippines has experimented with centers for excellence, including non-financial incentives like special administrative privileges for example, facilities that may pursue JCI accreditation might have special licensing privileges or a reduced kind of rigor in terms of the monitoring for performance. And then also Indonesia has this Puskesmas Paladin Award, which recognizes excellence in service delivery at several levels of administration. Finally, as I mentioned, in Thailand, accreditation does not always have to be clinical audit, and people stress that accreditation can be a process of peer learning and lesson drawing. And then finally, all quality endeavors were seen to be contingent on implementation. So in Philippines, there's a UHC law pending with the Senate. It's been passed by the House of Representatives, and now it's with the Philippine Senate. A lot of people, this would do many things that would fix kind of inefficiencies in the system. However, people are quick to stress that there's no shortage of good laws, like the law for the founding of PhilHealth that stipulates that accreditation must be conducted by a third-party provider. However, at the end of the day, it comes back to implementing laws and ensuring that they're in force. In Thailand, a lot of the some suggested that the financing gains through the universal coverage scheme overshadowed key early investments in central planning and supply side gains that allowed everything else to strengthen the quality of systems subsequently over time. And then in Indonesia, there's been a lot of momentum and a lot of movement and very strong political attention devoted to governing for quality. However, it's led to a lack of clarity at present as things are implemented and rolled out. And people were quick to stress that more emphasis needs to be placed on kind of establishing clear lines of communication and management across the system. So those are some of our findings for the study, and I'm happy to answer questions at a later part in the webinar. Thank you.
Thank you, Adam. Just to remind everyone, if questions are arising as you're listening in, please use the Q&A feature to submit your questions, and we'll address them towards the end. Now I would like to introduce, again, Dr. Shams Saeed, who currently coordinates the WHO unit focusing on quality systems and resilience within the WHO Department of Health Service Delivery and Safety. He oversaw the development of the architecture of the WHO unit as the strategic advisor for UHC and quality, and he currently oversees the global WHO initiative on national quality policy and strategy, which we'll hear about today. He also previously led the development of the implementation of the African Partnerships for Patient Safety since its inception in 2008. So with that, I'd like to hand it over to Shams.
Thank you very much, Althea, and good afternoon, good morning, good evening to colleagues. Next slide, please. In the next 10 minutes, I'm just going to give a very broad overview of the work related to the WHO initiative on national quality policy and strategy. And actually, Adam already alluded to this in his intervention. But I think it's a really important point that over the last 5 years, actually going back all the way to 2013 or 14, there's been a real global movement to enhance the linkages between the evolution of the universal health coverage movement and quality. And that culminated certainly in the clear inclusion of quality as within the fabric of UHC as defined in the Sustainable Development Goals, and a sequence of events that culminated in the publication of 3 really important documents. So very quickly, the first one was a WHO, World Bank, OECD report on delivering quality health services, the global imperative for UHC, clearly articulating the linkages. And we've seen 2 subsequent publications that have reaffirmed and really gone into some high level of granularity on the subject, emerging from the National Academies of Science in the US, but also the Lancet Global Health Commission on high quality health systems. All 3 publications really affirm this clear and consistent linkage that needs to be placed between quality and UHC. Next slide. Importantly, in the next slide, we shall see that for us at WHO, there really is no UHC without quality. And this has been recently articulated by our Director General. And as you'll see also, this clear articulation of the need for a national direction on quality, whether that comes through a policy level or a strategy level. Next slide, please. For sure, and actually Adam just highlighted this already, but all three of those publications emphasizes that all governments should have a national quality policy and strategy. Next slide. With that comes a responsibility to organize thinking around that subject, and perhaps in the first instance, why national quality policy and strategy? Ask the question and answer it. So for sure, there is, and even listening very attentively to the experience shared in this webinar, we can see that there are multiple initiatives that sometimes take place. The focus of a national quality policy and strategy should really be to organize that effort to improve quality of care across the whole health system, and importantly, clarify the structures for governance, accountability, and monitoring of national quality efforts. Further, the securing of the high-level commitment to quality is critical and key. And finally, and perhaps something that is very dear to my heart certainly, is the necessity to create a culture shift that supports providers to deliver and users to demand quality care. Next slide, please. So for us, within the work, it's always asked, well, what is it? What is a national quality policy and strategy? And I won't read this verbatim, but you can see what we're highlighting here is the necessity for an official explicit statement of the approach and actions required to enhance the quality of healthcare across a country's health system. And this, importantly, needs to be closely linked with a wider national health policy and planning process. This may seem very simplistic and obvious, but unless it's stated, sometimes we have a risk of creating a silo around quality, which is certainly not the intention. Next slide. The work of the initiative is really framed around this handbook for national quality policy and strategy. I won't go into the detail on the development process, but it is important to emphasize that it is not a prescriptive process guide, but is rather designed to support teams developing such policies and strategies. Also important to emphasize that it was co-developed with a set of 8 countries and received a lot of really important technical input from a number of technical partners. Next slide. So I'm going to take a couple of minutes to go through this in a little bit more detail. Many of you are actually familiar and in fact have contributed to the development of this handbook, but for those of you who are not familiar, let me go through the 8 elements of the national quality policy and strategy work. Now, all these 8 elements are clearly not, they're not sequential. They're all important, and sometimes 1 or 2 or 3 or 4 of them can happen simultaneously. But it just brings some organization to the thinking. Let me take a couple of seconds on each of those points. So we can see national health priorities. Again, might be quite obvious, but it's important to state that in making a national quality direction, it is critical to examine very carefully the national health priorities, and sometimes, and this we have seen through some of the co-developing countries, use specific entry points for that. So, for example, the entry point of quality of care for mothers and newborns, a hugely important population group, but for sure, quality of care for mothers and newborns should be seen in tandem with the quality of care for populations as a whole. So here we see an opportunity to use an entry point of a national health priority to take forward the discussions on quality. This might even come from the health security agenda. Clearly, quality and health security have huge interfaces. Second point, local definition of quality. For those of you who have examined some of those joint publications I was mentioning, clearly there is a consensus emerging around the different domains of quality. For sure, safety, effectiveness, and people-centeredness clearly hit the top list, but for sure there's multiple domains. How do we make sure that a country defines what it means by quality and paying clear attention to the domains that are put forward by the global knowledge pool? Third point, stakeholder mapping and engagement. How can the national direction on quality really utilize the mechanisms of stakeholder engagement that are required for ownership and transformational change? So a quality policy or strategy can probably be developed in a matter of 2 weeks, but if it's going to have the effect that we really want, we certainly are going to need a long-term stakeholder engagement process. Situational analysis goes without saying, but importantly, any strategy needs to be grounded on the on-the-ground implementation of services, really from the front line, subnational level, and of course, national level. The bottom 4, governance and organizational structure, I don't think I need to explain that to colleagues on this webinar, but critical linkages between organizational structures, governance, and the focus on national direction on quality. The point on improvement methods and interventions, now this is a vastly complex area. We've tried to organize our thinking within the handbook, and you'll see that the focus is on 4 blocks: system environment, reducing harm, improvement in clinical care, and the whole focus on patient, family, and community engagement and empowerment. Each one of those has various interventions that one could consider. And for sure, within the system environment, the whole concept of performance-based financing and contracting clearly come in. Now, we should emphasize that the expertise on this subject sometimes sits in different parts of organizations. In fact, even at WHO, of course, we have the depth of experience within the Health Governance and Financing Department, which is a sister department here. So here we are emphasizing that when we are looking at entry points into interventions to improve quality, that we think about it holistically and make distinct and informed choices related to that. The last 2 points are really hand in hand: health management information systems and data systems, and quality indicators and core measures. Again, vastly complex, but ensuring that linkage between a national direction on quality and the day-to-day health management information system. And also emphasizing that quality indicators and core measures should really be articulated and defined, not with a vast array of quality indicators and core measures, but a select few that can really drive the change that is required related to quality. That's easy to say, really hard to do, and many of the countries that we are working with are grappling with that, and that's where the joint learning really comes in. Next slide. Time is short, so I won't go into this in detail, but the fact is that we do not know all of the answers in this subject by far. And the idea that WHO is moving forward with is to ensure that there is a mechanism to share learning related to this space. And that's where we will certainly look to work very closely with you all. Next slide. So I am going to pause there and hand back over to Althea and look forward to any questions and reflections and learning from you all. Thank you.
Thank you very much, Shams. Now, at least I would like to invite our colleague Irina Guban from Moldova to share her country's experience. Irina is an economist working for the World Bank in Moldova. Her primary area of expertise is health sector development. She's provided active support to primary healthcare strengthening, contributed to hospital optimization reform agenda setting, and dealt with the analysis of health financing issues. Most recently, she participated in the public expenditure review of Moldova's healthcare sector and is in health sector policy dialogues. So I will hand it over to you, Irina, to talk about Moldova's experience.
Good evening, good morning, everyone. Let me quickly walk through the Moldova's experience, and then I will leave more time for questions and answers. As you can see, Moldova is a small country between Romania and Ukraine in Europe with a 3 million population, and with that we have mandatory health insurance implemented since 2004. In terms of governmental health spending, we spend more or less equally like the countries in the region, roughly around 10%. However, we have many problems that are also similar to small countries, like high level of out-of-pocket spending, which goes up to 45% of total health expenditures. We have excessive hospital network with 73 public hospitals in total, and around 10 private hospitals. With this, we have a lot of inefficiencies, which are mainly in hospital sector, and the health outcome are, given this level of spending, are still suboptimal. Let me move to the next slide quickly. Next slide, please. Yes, and you can see this is a health system organization in Moldova. As I said, we have a health insurance fund, which is pooling financing from employees and employers and purchases on their behalf healthcare services. And we have National Agency for Public Health, which is under the Ministry of Health, Labor, Social Protection, which is in charge of accreditation and controlling functions. Basically, all the healthcare institutions need to go through accreditation process. And in order to optimize all the controls that have been excessively spread through all the other agencies 9 months ago, this government optimized and put all the control functions under National Agency for Public Health. So you can see that we have district hospitals, we have municipal hospitals, tertiary care institutions, and we have primary healthcare centers. If we can move to the next slide. Yes, so accreditation process in Moldova, unfortunately, is still in the process of reform, because we have current up to now the accreditation is more accrediting buildings, facilities, rather than services or processes. And unfortunately, this is because of the limited purchasing power of health insurance funds, still institutions that are provisionally or conditionally accredited will have to be contracted for health service provision, because otherwise certain remote areas would have impaired access to healthcare services. However, starting 2008, the country has introduced pay-for-performance in primary care. Since next year, the health insurance fund will start piloting pay-for-performance in hospital care in 16 most advanced hospitals. There is already a complaint mechanism that is run by different institutions in place, which actually provides possibility to shift monitoring of quality to citizens, and based on that, to take an action on certain healthcare institutions which are non-performing. This year, there was a pilot experiment, a policy experiment on the implementation of a hospital performance report card, and I will talk a little bit about that later on. And of course, there's another measure of non-monetary incentive to improve quality of care. We have a National Healthcare Gala Award for health professionals, which contains around 9 or 10 awards per area, in primary care, in hospital care, public health, in medical profession like medical teaching, and so on. I will be a little bit more specific on primary care quality monitoring and on hospital care, if you allow me. Next slide, please. So as I said, the pay-for-performance mechanism in primary care was launched in 2008, starting with a minimum 4 or 5 performance indicator. It was reformed, increasing the performance and the scope and the number of performance indicator starting from process indicators to moving to outcome indicators. This mechanism is still in the dynamic process of improvement, and this year still the Ministry of Health, Labour, Social Protection is working on how to make these indicators more targeted to change the modality of healthcare provision by family doctors in a way to improve their day-to-day practice. But with all this dynamic process, still there are good results of implementation of this P4P mechanism. For instance, in infant mortality, we have a decline by 10% of deaths per 1,000 live births since 2008 up to 2016, and there are also improvements in the early diagnostic of cancer and in monitoring of pregnant women and other pillars which are mainly stay with the primary care scope of work. So the scheme provides 15% of budget or amounts to 15% of budget dedicated to primary health care, and is paid upon the submission of results and once these are verified. The only problem with this P4P is that we are now at the final stage of the before we deploy electronic health records, and in the absence of accurate data and health management system, it's very difficult to monitor the accuracy of data, because now it's a lot of administrative burden on health insurance fund in terms of costs related to deployment to the family center, family doctor center, and also in terms of verification of health records per se. Next slide, please. In the hospitals this year, the health insurance, together with the ministry, identified 10 outcome indicators which will be piloted in 10 hospitals, and they allocated a top-up 5% of hospital budget to be paid as a bonus, like as a positive incentive to hospitals to start improving their quality. This mechanism is still going through the final stage of fine-tuning, because this where an important aspect of this is availability of hospital information management system, but also health insurance fund is working on automating this system, because there are many hospitals and many indicators which have to be verified and then calculated for payment. So the health insurance now is automating this system basically. This will be deployed starting January next year. But this addresses outcomes some of them are related to hospital, like 2 or 3 are related to hospital efficiency as another dimension of quality. In health insurance fund and other Ministry of Health, Labour, Social Protection, but also Consumers Protection Agency have a hotline service, and there is a regulation in Moldova that says that if there is if there is a proof from a patient who was hospitalized, if a patient brings a receipt that he was asked by family doctor to pay for some consumables or for medications and were not provided these while during the treatment, so health insurance fund will not pay for the entire case treated to that specific hospital. So this is a very good instrument, and actually which is growing popularity recently. Another good experiment, policy experiment that we have conducted was the implementation of hospital performance report cards in 9 treatment districts against 9 control districts. Basically, this was the dissemination of information about the quality and performance of hospitals to citizens. In this way, empowering them to choose secondary level hospital in that area. And actually, the first results that I have seen this morning after implementation of this experiment were very positive, showing that in the treatment rayons, almost 80% of patients after this policy experiment became aware with the quality of care. They started choosing hospitals on their own more actively, and in this way steering up quality improvements in medical institutions. And again, it's always good to have other recognitions such as very mediatized awards, remunerating or acknowledging outstanding performance of healthcare professionals, which is also brings a lot of reputation to healthcare professionals, and they stimulate themselves to be better positioned. Being small country, importance of such an award is very high. Can we move to other slide? Yes, so let me quickly walk through main challenges. The main challenges are mainly, I would highlight them as the availability of health management information system, of empowering citizens to participate in monitoring of equality, but participate making or imposing an informed decision, leveraging and informed decision making by patient to choose their institution for healthcare institution, and also to streamline citizens' complaint mechanism, and showing the citizens that their feedback counts. That's very quickly in terms of linking quality to health financing. In Moldova, we are not at a very advanced stage, but we are already at a stage where we know the lessons learned. What was important for Moldova at this stage was to really have good, accurate data, and in order to minimize administrative costs, but also to empower citizens for monitoring the quality. Let me stop here because I think I took already too much time, and I'm open for questions.
Thank you very much, Irina. So now we will move on to questions and answers. So if you have you have not already submitted it, please do so through the Q&A feature at this time. And then if your question should be addressed by a specific panelist, please indicate that as well. And any questions that we don't get to, since we're running out of time, we can address via email as well. So there are a few questions that have already come in. So while people are submitting their questions, maybe we can start with that. Adam, I think this is a question for you. The question is, if implementation of laws for quality is one of the bottlenecks, how can this be overcome? Are there lessons learned from the three-country study to put policies into practice?
Okay, sorry, Altea, what was the first part of the question? I don't see it on the screen.
If implementation of laws for quality is one of the bottlenecks, how can this be overcome? And if there are lessons learned from the three-country study that highlight how that can be done.
Yeah, I do think that part of this, this also goes to the question from the person online who's asking about tertiary care and pediatric surgery. It's part of the same question. I think that one of the points that Shams highlighted nicely, maybe he wants to comment in a second, is that we really need to reframe kind of our thinking around quality in a lot of the countries. And I think this does start at service provision level. And there's really like 5 main reasons that I can think of off the top of my head that others have pointed to for why we should focus on quality. The first, and communicating this to providers is, and as well as health officials within the system is a key step in reframing the message. The first is that 8 million deaths per year have been attributed to poor quality of health services, and this has resulted in like $6 trillion in economic losses. This positions poor quality health services are now a bigger barrier to mortality reduction than access issues, than poor access issues. The second one is that the poor are disproportionately affected by poor quality services, so it exacerbates inequalities. The third one is that epidemiological transitions and increasing healthcare utilization positions quality as a primary driver of population health. And then the fourth point is that poor quality leads to unnecessary suffering, adverse outcomes, and a lack of trust in the system. And as I mentioned, this has severe economic consequences attributable to systemic inefficiencies. And then finally, access gains will be moot if people don't seek services, and we know that people won't seek care if they don't value the services that they're receiving because they're perceived to be inferior in quality. I don't know if any of the other panelists want to pick up on any of those points.
Thank you, Adam. I'd like to move on to another question, maybe for Shams. This is related to the definition of quality and the dimensions of quality, and the question is, should there be a distinction between different service lines in terms of how you define and monitor quality? And also, another part of the question is, would it be recommended to start with 1 or 2 service lines as a test?
Yeah, both of those questions are great. For sure, I think for us within the learning that we've had to date is that there's often a really important entry point, and which is somehow linked to the frontline experience. And I think it just building on what Adam was highlighting is that for us, the realities of implementation that are being put forward by health workers can really bring that drive and focus to the national quality endeavor. Whether one focuses in on one specific area of services or not is certainly a decision that perhaps should be made at the most local level. But the whole idea of having a national direction on quality, whether that be through a strategy or a policy, is to bring all the thinking around quality in a comprehensive and strategic way. So just taking a real example, let's think about Malawi. Now, Malawi has had a clear focus on the quality of care for mothers and newborns. So certainly that's a focus that they have made a decision on. But what they have also decided on is that that would be a part and be a somewhat of a pathfinder for their overall approach to quality health services in a comprehensive and a strategic manner. So whether we start, and of course, you know, when you start, you have to start small sometimes, but with a clear strategic direction for the longer term, and that has to be a comprehensive view on quality services in totality, taking a very clear health systems approach. But having said that, we do recognize that in the real world, there are certain times where things move, and then there are multiple quality projects and initiatives that are going on. Our task in that sense would be to learn from those experiences and translate that into more of a strategic approach for the longer term. Back to you, Althea.
Thank you, Shams. Unfortunately, we are out of time at this point, but I see that other questions have come in, and we are happy to answer those via email as a follow-up to this webinar. So with that, I would like to wrap up now, and I hope that you have found the information and the discussion today useful. I want to remind you again of the two resources that we presented: the practical guide for defining institutional arrangements when linking financing to quality in healthcare, and the National Quality Policy and Strategy Handbook. So we will follow up with links to these. And I would like to thank you again for attending the webinar today, and wish you a good day or evening, depending on where you are. Thank you very much.